Well, Dr. Hanna, why don't we move along in the meantime and have you come and talk to us about the concept of whether surgeon safety impacts patient safety.
Thanks for the opportunity to speak to you today. I thought first is to speak of what do we mean by patient safety and what the parameters we're going to use to speak about patient safety. If we are going to speak from the ergonomic perspective, we really we can move a bit far from the morbidity and mortality for a few reasons. If we look at morbidity data does not correlate complications to specific errors or underlying factors because a complication can have many factors, contributing factors, and does not provide methods to improve performance. It's like a black box. What we say, a complication happens. We don't know how to avoid it. And allow adverse events to accumulate while a study in process. So we have study to finish before we know what's the outcome. And during this process, complication would happen. So really, the morbidity data is like a post-mortem of living people. Damage has already happened. And if we're going to use mortality data, the analogy for this is a famous picture of the Battle of Waterloo, and this is after the battle. What happened now? They are counting the body. So our mortality data is a counting body data. It doesn't address the problem really. Allow a problem to happen, and then we address it later on. Now, in high reliability industry, they don't wait for the disaster to happen, but they address it at a near miss level or errors level. Give you another analogy, which is people fail the driving test if they go through a red light. They don't wait to crash their car to fail a driving test. And from the ergonomic perspective as well, we don't need to wait for the complications to happen, but we can address it at a near miss or an error level. And therefore, when I'm going to speak today, we're going to say, does patient safety impact task performance in general terms, not only the patient safety in terms of morbidity and mortality? And if we are going to speak from human factors, what we can say that we are going to speak about performance shaping factors. What are the issues which makes task change? And in this prospect, we're going to speak about surgeon safety. So I'm going to speak about three areas today: is sleep deprivation, stress, and mental and muscle workload. And I'm going to speak with regard to the influence in patient safety. Now, this is a famous Nature paper which showed that after 17 hours of sustained wakefulness, the performance in a psychomotor testing equivalent to moderate alcohol intoxication. And when they waited 24 hours, this was equivalent to the performance of people who have alcohol intoxication above the limits for driving. And then, coming to surgery, this is a study done in simulation, which showed that people who are awake after night, they make 20% more errors and take about 14% longer execution time. And this is a New England study in intensive care, which showed that people who extend their work, they have more decrease their attentional failures using ocular muscle EMG. They saw they stay more and they commit more errors. So basically, what this means that with a sleep deprivation, then surgeon or physicians make more errors. Coming to stress, I'll share with you the couple of studies we have done at Imperial. It was the first study was not in laparoscopic, but it was a carotid endarterectomy simulation, 30 surgeon, and for a stress, there is a self-assessment by state and trait inventory, and there is an observer assessment by the assistant, and use the heart rate variability and use salivary cortisol as a measure of stress. And the outcome measures was assessment of technical skills, assessment of teamwork, and the quality of the end product as an outcome measures. And the conclusion of this study was that coping with the stress significantly improves the quality of the end product and enhance non-technical skills. So I said, if this is the case, so what can we do is we can do another interventional study. So we randomized surgeons into two groups. Groups with a standard procedure, and the other group have a stress coping strategies. And this shows that with stress coping strategies, this is improve technical and non-technical skills. So we concluded from those two studies that stress in the operating room and with surgeons impact task performance. Coming to the third point, which is the mental and muscle workload. I'm not going to speak about musculoskeletal because you can see it's been covered before, but I just take a couple of examples and see how the ergonomics of imaging influence task performance. This is the imaging modality. This is a study which we compared direct division in 2D and 3D, and obviously you can see that direct eye with the eye is much better than imaging, which we know before. But when we looked at the mental workload using blanking rate, showed this is direct vision, 2D and 3D. And actually 3D even get more than 2D. But what it shows that imaging inherently increase mental workload, especially if you get a 3D. And we've done the same as well with this study as well, which showed that direct vision has lower mental workload than 2D and 3D. So imaging inherently can cause increased mental workload. Give you other example, which is the imaging, where we put the monitor. The earlier studies we have done showed that the monitor should be located in front of the surgeon to get the visual and motor access in the same plane, and close to the operative field to get the proximity of the sensory and motor information. But if we study this in more details, this is we using tracking systems, tracking all the angles of the back, the neck, but this angle is a vertical, horizontal neck to vertical angle, this angle. Now, what this slide shows, here is eye level and here is gaze down. So with eye level, with time, the surgeon tends to move their head around to the front. And this is translated to more workload of the trapezius muscle. And translated as well to more mental workload if you use the skin conduction as a measure. So this is gaze down and this is gaze up. So the change in the mental and physical workload results in less execution time on the monitor in front of this patient and very close to the working space. Does this affect task performance? Yes. In terms of suturing error score, when the monitor looking down at the level of the operative field, it gets less error than which is in front of the surgeon at or higher than the eye level. And also shown that there's improvement in task quality and execution time with the gaze down stance. And this is more you can appreciate it more when there is increased in task complexity. The question really, this is translated to a clinical work case. There was a randomized controlled trial of laparoscopic appendectomy in children, which showed faster execution time when the monitor in the line compared to standard placement. So in this study, used it in the line near the operative field. Just to conclude quickly from those few points is fatigue and stress impair task performance and increase medical errors. And the ergonomics on the endoscopic imaging influence mental and muscular workload and impairs task performance. So really coming to the question is, does surgeon safety impact patient safety? Yes, because it changes the level of the stress, fatigue, mental and physical workload, and this reflected either into medical errors and reflected into task performance. And those are the 3 PhD students who done the work which I presented. Thank you.